welcome back to another episode of Ask 360, where we are answering all your questions related to health and fitness. It's been a while since we've done one of these, but we've got a question here from Lucy. And Lucy says, I'm having pain in a number of different areas and am considering an injection. Friends have told me that injections have helped with their injuries, but I've also read that they have side effects. What should I do? Thank you very much for your question, Lucy. The topic of injections for musculoskeletal pain is a huge one. And there are a lot of different injections that are used to treat musculoskeletal pain. And they all have different advantages and side effects. And we'll go through some of these different injections here and talk about some of the conditions that they may or may not be useful for. From the outset, we need to understand that all injections carry some type of risk. So there's always the risk of infection when we're breaking the skin. There's a increased risk of pain due to pressure around the sensitized structure. So often injections will have an analgesic effect, but sometimes they can have the opposite effect and make things worse. And then we can get systemic side effects such as nausea and fever and headache. We can get soreness around the injection site, which I guess for most people is probably less of a concern. It's a temporary side effect and not that severe. And then depending on the medication that's used, we can have an adverse effect in terms of an allergy to a specific substance. So all those side effects need to be taken into consideration if we are looking at injections as a potential modality. We'll talk about some of the different injections that can be used for musculoskeletal pain. When most people think of a painkilling injection, the most common painkilling injection and historically the most widely used is a corticosteroid injection. Corticosteroids are powerful anti-inflammatories and is a synthetic version of cortisol, which is a steroid produced in the adrenal gland and is released into the bloodstream in response to stress. And this functions to suppress various elements of the immune system, in particular prostaglandins, which are hormones produced at the actual site of the injury, as opposed to most hormones which are produced in the other areas of the body and then taken to the injury site. Because of this powerful anti-inflammatory effect, corticosteroid injections can be very effective in addressing pain. However, because of the strength of the substance that we're injecting, they can have a degrading effect on the tissue. So in a joint, if we're injecting a joint, then it may actually cause some damage to the cartilage, and it may actually speed up the degeneration process. So if you are having injections for an acute joint injury or perhaps a degenerative joint, such as an osteoarthritis condition, then injecting a steroid into that area may actually speed up that joint degeneration. Likewise for tendons, if you inject directly into the tendon, then it may actually increase the risk of tendon rupture. So because of this, corticosteroid injections tend to not be performed in high doses. So typically you would only have 1 or 2 corticosteroid injections. Any more than this, and you are really increasing the risk of secondary damage to the injection site and to that tissue that you're treating. We also tend not to, or at least say for a last resort intervention, inject into large weight-bearing joints, such as the knee in particular, and also the hip. And also, we don't inject directly into the tendon with weight-bearing tendons. So something like a patella tendon, which is where the quadriceps muscles attach into the front of the shin, or the Achilles tendon at the back of the heel. These are large weight-bearing tendons, and injecting into these tendons actually increases the risk of tendon rupture. However, If we have what we call a paratendon injury, where it's not actually the tendon that's causing the pain, it's actually the sheath which encases the tendon. Sometimes in these cases, we can inject just into that sheath and avoid injecting into the tendon. However, we still need to be careful with this, because when we're injecting into an area, you sort of get the chemicals that you're injecting spreading out and dispersing, and some of that can still affect the tendon. There are other upper limb conditions that are commonly treated with corticosteroids, such as a rotator cuff tendinopathy in the shoulder, or a lateral epicondylalgia or tennis elbow. These have been historically treated with corticosteroid injection. However, the research would show that injection is no better in the long run than a more conservative management approach. So we do get some temporary pain relief, and in some instances this might be necessary to really settle down an area if nothing else is working, and allow us to apply some of our other treatment modalities, such as exercise-induced loading and things like that. But this should really only be kept as a last resort, because not only does it not lead to better long-term outcomes, but it can actually make things worse in the long term. There are some conditions where it might be a little more appropriate. So very small joints, such as a toe. I know this from my personal experience. I had a bad case of bony edema, bony swelling in my toe, and that actually responded very well to a steroid injection. A small joint such as the AC joint, again, from personal experience, I've had injections into my AC joint, which is sort of where the collarbone joins onto the shoulder blade. These joints, especially in the AC joint doesn't do a whole lot. There's not a whole lot of movement there. So the risk of degradation to that joint is not as great. And steroid in this area can actually be really effective in addressing pain. Again, because of the risks involved and the potential side effects, it's not something we'd rush to as our first line intervention. But if we're getting to a point where, in our rehabilitation, where we're not getting improvements with more conservative measures, then it's a consideration. So another area where there's potentially a little less risk with corticosteroid injection is in the heel. And this time we're talking about the base of the heel rather than the back of the heel. A common condition that we see is plantar heel pain or plantar fasciopathy. We used to call this condition plantar fasciitis. Where you have an irritation of the soft tissue on the base of the foot. And this can be a condition that stays around for a long period of time. We can have good success treating this with specific exercise and load management and addressing someone's biomechanics. But if this goes on for a long period of time and they're not responding to this, we may potentially use some other modalities like shockwave therapy, which is shown to be somewhat effective in that area. But again, if this is ineffective, then the steroid injection may be an alternative that we might use. And unlike tendons, where it has shown to be associated with an increase in rupture, injection into the plantar fascia, in the studies that we've seen more recently, that actually hasn't shown to be associated with an increased risk of rupture. Corticosteroid can also be used to treat bursitis. So bursitis is an inflammation of the bursa. Bursa is a sac of fat, sac of fluid that sits in areas of increased friction and basically acts to try and decrease that friction. And these can be irritated via overuse, or they can be irritated acutely, either by some joint-related movement or acute trauma. And these can sometimes respond well to a steroid injection. We do still need to be careful, because often these bursas lie near tendons, and so we need to make sure that we're injecting directly into the bursa, and we're only using a volume of steroid that's not likely to seep out and interact with a tendon. Another condition that can respond quite favorably to a steroid injection is a frozen shoulder. So frozen shoulder is quite common in people, particularly in the early 50s. And it's going to be very, very painful. So we usually go through phases of this condition where it starts off as a painful condition, and then over time the pain decreases but the stiffness increases. And in this painful stage, if someone is having a lot of trouble sleeping and they're in a lot of discomfort, unfortunately, from a physiotherapy perspective, there's limited intervention that we can apply. We still can have some success with physiotherapy, but it's not always the case. So if someone isn't responding to our conservative management, an early stage frozen shoulder is one of the conditions where I actually feel a corticosteroid injection is probably warranted. So the next injection we'll talk about is a hydrodilatation, or also called a hydrodistension. Now, this is typically used to treat frozen shoulder, which we talked about before, and this would be used more in the late stage of a frozen shoulder. So if someone has got past that painful stage and they're in the stiff stage of a frozen shoulder and they're not really getting anywhere with the stiffness, and the stiffness is really impacting on their daily function, their occupation and their activity, then it's something we can try. So basically, we're injecting a lot of saline into the joint space and trying to stretch it out and trying to loosen some of those contractures that form with the frozen shoulder. I have seen some good responses to this, and in the research, it has been shown to be effective. However, some people will have a negative response as well, because even during the stiff stage of a frozen shoulder, pain still is a factor. And when you're injecting a whole bunch of fluid into a joint to try and stretch it out, there is always the risk that it can increase pain. So we sort of take this on a case by case basis. Whenever we are injecting steroids, because of the risk of sort of the steroids seeping into other areas of the body, it is important that those injections are guided. So ideally, we want to have an ultrasound where we can actually view the tissue that we're intending to inject. Another injection that's actually quite common in Japan is a hyaluronic acid injection. So hyaluronic acid, also known as hyaluronan, is naturally found in joints and is decreased in conditions such as osteoarthritis. So the theory behind injecting exogenous hyaluronic acid is that you're basically topping up that body's natural supply, and by doing so, having almost like a lubricating effect. This type of injection, it's because it's a naturally occurring substance in the body, it doesn't have the same sort of side effects as a corticosteroid injection. So it's something that can be used more frequently. So often this might be given as a course of 2, 3, 4, 5 injections, or it might be something that someone has every 6 months or so, almost as a top up to keep topping up the that joint's natural supply of this acid. Even though it has less side effects in comparison to corticosteroids, it tends not to be as effective. There's not a lot of research behind it. There are some papers to show that it's effective, but it's certainly not effective to the same degree as a steroid injection. So this is something that we might use with someone who is suffering from osteoarthritis that is really struggling to get over the pain associated with the condition. So, our first line treatment for osteoarthritis is always exercise, but some people are in a lot of pain and they can't actually get to the point where they're starting to exercise. And so for them, this is something that we might try, but we need to set realistic expectations with this and also take into consideration the possible side effects that we talked about at the start of the show. An injection that's become quite popular in the last 10 to 15 years is a platelet-rich plasma injection, or PRP. This is where we're basically taking the patient's blood and spinning it around in a centrifuge so that we're separating the platelet-rich plasma, so all the high platelet content of the blood. And then we're injecting that back into the body. And the thought is that by doing this, we're speeding up that healing process. This is one area of orthopedic medicine where the clinical usage of this intervention has sort of rushed ahead of the research. So it's been used quite extensively, both in private practice and also especially in professional sport. It has almost a trendy type of stigma to it. It is quite popular because it has been used in professional sport. It is quite expensive, and so professional or sporting organisations often have the funds to be able to administer this to athletes. However, at the moment, we still don't have a lot of research behind it. But there are starting to be more findings emerging from the research to suggest that there is some clinical utility for it, both in terms of muscle injury and joint injury, but it's still the effectiveness in terms of pain relief and even speeding up recovery and return to play is still nowhere near the degree to which we see with corticosteroid injections. But because it's our own blood that we're injecting, we're not seeing those side effects that we see for steroid injection. So we need to take into consideration a lot of things, and one is the cost. It is quite an expensive intervention for something that's not really been proven to be super effective. And because of the lack of research for findings, often insurance companies won't pay for this. So we need to take that into consideration. There is a little bit of a gamble whether it's effective or not. But if someone is struggling with a condition that's not responding to conservative management in the way that we expect, and they're willing to take the risk as far as the cost is concerned, or if the health insurance company is willing to pay for it, then it is something that might be worth trying. Another injection that is more widely used in Europe than in Japan or even places like Australia and the United States is called prolotherapy. And this is a type of regeneration therapy. It is controversial and there's not a lot of evidence behind it, but the theory is that we're injecting a natural irritant, often a sugar or salt solution, and it's basically meant to stimulate healing. We have seen this used occasionally. The area where it seems to be most effective is in the sacroiliac joint, so in the pelvic region. So sometimes with pelvic problems that aren't responding well to conservative management, or are very painful and not allowing us to really get started with the management approach that we'd usually recommend with these type of conditions. Again, it's a lot less risky than a corticosteroid injection. Again, we're not expecting the same level of pain relief, but it's something that we might want to try. The last injection we'll talk about is a drug called Hernicor. So with a Hernicor injection, a substance called Condolease, which is a chemonucleolytic drug, which basically chemonucleolysis basically means using a chemical to help dissolve a structure. So in the United States, a similar procedure is used with a drug called chemopapain. And the Hernicor injection was approved in Japan in 2018. And basically, we're injecting this substance into the disc of the lower back, and it's been shown to decrease the size of a disc herniation. So we're injecting into what we call the nucleus pulposus, which is the part of the disc that may herniate and contribute to pain or to some nerve-related disorders. And it's been shown to basically shrink the size of that bulge. It's less aggressive and less risky than surgery. So the theory behind it is it's having a similar sort of effect to as if you were going in and dissecting that herniated portion of the disc, but it's obviously a lot less invasive. When considering the use of a Hernicor injection, we just need to take into consideration the relevance of a disc bulge, because for a lot of people, a disc herniation or a disc bulge might be seen on MRI and might be seen in someone with lower back pain or even sort of lower back related leg pain, but have actually no significance or no correlation to their symptoms. So the times where this might be useful is if a disc herniation is pushing on a nerve and it's causing symptoms that would associate with a compressed nerve, such as numbness and weakness and loss of reflexes. So for those type of patients where they're experiencing neurological symptoms that are worsening over time, then the Hernicor injection might be an option for them that might be used instead of surgery. And we have started seeing patients having these injections performed in Japan, and we have seen some positive results. So, Lucy, I hope that's given you some sort of information. The topic of injections in relation to musculoskeletal pain is a huge one, and it's something that needs to be really discussed thoroughly with your medical provider. But I hope that's given you some information in terms of the different injections that are used, and where we see that they may be effective and where they probably shouldn't be used. So thank you very much for your question. Anyone else has any questions, please send them through, and we'll look forward to seeing you on the next episode. Thanks for listening.